Well, one of the major questions around the TAVR technology is the, let's say, cerebral protection issue. Because when the TAVR has been introduced in the clinical arena, it actually fulfilled an unmet clinical need. However, along with groundbreaking results, we immediately understood that the cerebral protection was an issue because we had an excessive rate of stroke as compared to surgery, meaning that, well, let's say in all the major trials, randomized or registries, the percentage of patients having a stroke after TAVR was around 5 to 6%, which is actually something that is hard to believe, but also hard to accept, particularly when we are dealing with younger patients, particularly for the future. Well, I actually conducted a meta-analysis and a systematic review, including all the available evidence coming from randomized controlled trials as well as study registries. And by the way, all the available devices were there, and also some of them are no longer available in the market. So the idea was to collect all the possible available evidence in the literature and to understand what is the real impact of these devices, particularly because every single study itself is not powered to give clinically meaningful results. So that's also the key of any meta-analysis. Well, the major result of this trial is that there's no advantage for the cerebral protection in terms of survival. So there's no advantage in terms of overall mortality, but also in terms of stroke, there is a slight advantage, meaning that there is only one study showing a positive impact of this technology. But also, this study is a registry and has been done with a particular methodology, which is actually some kind of propensity score matching, which is not randomized controlled trials. So overall, I would say the cerebral protection technology nowadays was not able to provide an advantage in terms of mortality, and in terms of stroke, it's just a signal of benefit. So this data, unfortunately, are still inconclusive. Well, definitely what we know is that we need to find out how to select who is the right patient for cerebral protection. And it has to do with several things, particularly with risk of embolisms coming from the aortic arch, from the valve, also from the aortic root. So we cannot support the idea of using this technology in all patients. However, there are some cases in which this technology is clearly beneficial. And the next step is to understand who is the right patient. Well, actually, with the diffusion of the MRI to assess this patient after TAVR, what I would like to see is a trial with a clinical endpoint, but also with an MRI assessment. Because what we clearly know is that there is a rate of around 80% of the patients with some degree of brain damage, according to the MRI. However, the rate of clinically meaningful stroke is around 5%. So there is a big discrepancy. So in terms of future trial, well, I would say a trial with a clinical endpoint, but also with an MRI assessment, comparing a selected population in which the risk of stroke is higher as compared to clinical and anatomical factors, and two arms. One arm without cerebral protection, the other arm with procedural protection.